Welcome to the deep dive. Today we're going to really get into health disparities and health equity. Now, these might sound a bit academic, maybe a little dry,
Yeah, they can sound that way.
but how they're actually defined, it has these huge real-world impacts. We're talking policy, resources.
Absolutely. It's critical.
So our mission today is pretty clear. Let's unpack how these definitions, which seem academic, have such practical consequences.
Exactly. And, when we talk about health disparities, sometimes people say health inequalities.
Yeah.
They're often used the same way. It's really important to get that we're not just talking about any old difference in health.
Okay.
It's specific. It refers to when disadvantaged social groups systematically have worse health or face greater health risks than groups who are more advantaged.
Disadvantaged groups, so like based on income or race.
Precisely.
Yeah.
Poor communities, racial or ethnic minorities, women in some contexts, people with disabilities,
Yeah.
groups facing systemic barriers compared to, well, more privileged groups in society.
Okay. Can you give us an example, something concrete that really shows what this looks like on the ground? Because I think that really drives home why the definition matters so much later on.
Yeah, absolutely. Here's a really stark one from the U.S. The infant mortality rate among African-American babies is 14.4 per thousand live births.
Wow.
Now compare that to European-American babies. It's 5.7 per thousand.
Yeah, more than double.
More than double. It's really sobering statistic, isn't it?
It is.
And seeing that kind of number, it just highlights why getting these definitions right is so vital. It's not theoretical. And when we say social advantage, we're talking about someone's relative position, determined by wealth, power, maybe prestige, things like money, education, job type, sure, but also these bigger structures like gender, race, disability status, sexual orientation. They all play a role in this hierarchy.
Yeah.
There was Margaret Whitehead back in the early 90s. She had this really influential definition. She said these health differences are not only unnecessary and avoidable, but in addition are considered unfair and unjust.
Unfair and unjust. That adds a really important layer.
It does. It brings in the ethical dimension.
So why does nailing down the specific definition matter so much for, say, governments or health organizations?
Well, it directly impacts what gets measured,
Yeah.
what health statistics are tracked by governments, by international agencies, and crucially, what gets funded.
Ah, the funding, right.
Exactly. There was this interesting period at the World Health Organization, the WHO, between about 1998 and 2003. New leadership came in, and they tried to shift the focus. They moved towards measuring health differences across individuals, but sort of ungrouped.
Ungrouped. How does that work?
Kind of like how economists measure income inequality using something like the Gini coefficient, where a number shows the overall spread.
Okay, I think I follow. So let's focus on comparing specific groups, like African Americans versus European Americans in your earlier example.
Exactly. Instead of comparing specific social groups, it looked at the overall distribution of health across everyone.
Right, and I remember hearing that shift get some pushback, didn't it? That people were worried it was like removing the ethical side.
That's precisely it. The criticism was that it took out the ethical and human rights considerations from how health differences were being measured.
So what were the practical consequences of that kind of shift?
Well, let's think about it. Under that proposed WHO definition, take a situation where, say, women generally live longer than men.
Okay.
Or maybe where affluent European American women have a higher rate of breast cancer incidence. Now, those are definitely important public health issues, no question.
Sure.
But under that specific WHO proposal, they wouldn't be flagged as health disparities that need special health equity resources.
Why not?
Because those differences don't put an already socially disadvantaged group at a further disadvantage relative to more privileged groups. Women living longer doesn't disadvantage women as a group in the same way systemic racism impacts infant mortality for African Americans.
Ah, I see. It's about that intersection of health difference and existing social disadvantage.
Exactly. It fundamentally changes where you direct attention, resources, and importantly, accountability.
It makes sense why focusing on already disadvantaged groups is key from an equity perspective. But just to play devil's advocate for a second, couldn't someone argue that focusing only there means you might miss other important health problems affecting other groups, even if they aren't disparities in this specific way?
That's a really fair point. And the idea isn't to ignore other health problems at all. Public health has to address the health of the whole population. But the equity focus, the reason for this specific definition, is about prioritizing. It's rooted in ethics, like distributive justice.
From philosophers like John Rawls, right? Prioritize the worst off.
Precisely. prioritizing improvements for the most disadvantaged members of society. And it's also tied into core human rights principles, the right to health, non-discrimination. And this leads to a really critical point about measurement.
Okay.
To genuinely assess health equity, you have to consistently compare the health of disadvantaged groups to the health of the most privileged group in that society.
Not just to the average health of everyone.
Not just the average. Comparing to the best-off group sets a higher bar. It really forces us to look at the policies, the social conditions, the systemic things that create those gaps in the first place. It fosters accountability.
So it really sharpens the focus on closing those specific gaps driven by unfair social structures.
That's the core idea.
Okay. It's become really clear how getting these definitions right isn't just semantics. It directly shapes who gets help, what problems get tackled, and who's held responsible in public health. So, this brings us to a final thought for you, our listener. How might understanding this distinction between any health difference and a health disparity rooted in social disadvantage, how might that change how you look at public health debates? Especially, when resources are tight and tough choices have to be made to really try and achieve health equity for everyone.